All right. So good morning, everyone. Welcome to our February 6th meeting of the,
This meeting is being recorded.
as you know, this meeting is being recorded, to the Medical and Professional Affairs Committee. If I can, I'd like to get the minutes from our last meeting approved. Get a motion?
So moved.
All right. Could I have individuals then? Dr. Katz?
Yes. Yes.
Okay. And not here. Okay. So we're good. And I'm saying yes as well. So, all right. So minutes are accepted, and on to Dr. Allen for our first resolution today.
Good morning. I would first like to introduce Richard Freeman, the Senior AVP for the Office of Behavioral Health, and Jennifer Morrison Diallo, Director of Mental Health Services, Kings County Hospital. For the committee's consideration, authorizing New York City Health and Hospitals Corporation, referred to as the system, to contract with MSS ARC Inc. for respite services for adult patients with intellectual or developmental disabilities for a term of 3 years with 2 one-year options exercisable only by the system for amount not to exceed $8,500,000. Mr. Freeman?
Morning. So I'll give you a little background on the importance of the IDD unit, the respite unit. Respite services provide an opportunity for families of patients with intellectual or developmental disabilities, or IDD, to have them support managing care of their loved ones. There's a lack of respite services for adults with IDD in New York City. Resources are mostly for children who reside in the community. These lack of crisis respite services results in high utilization of emergency room services due to crises that could have been potentially averted if there were other options. The program, AHRC, some of the clinical services, there are 5-bed respite for individuals who can be connected and enrolled in OPWDD, but pending approval and in need of housing. They're currently, ARHRC is currently the only ID service, respite service in New York City. It's located in Brooklyn. They provide crisis emergency support for individuals living in family homes. They provide testing and other community linkage services to aid in the enrollment for OPWDD waiver services. AHRC Respite House individuals receive a continuum of specialty services similar to what they would receive in the community when transitioning into permanent OPWDD group home. Care coordination, psychological and behavioral support services, peer counseling and vocational rehab services, groups by licensed creative arts therapists, and 24/7 clinical care by a 2-to-1 individual to staff ratio. The admission criteria, they only take individuals who are currently in the New York City Health and Hospital facilities, which includes CPEPs, psychiatric or medical inpatient units. Individuals must be able to connect to OPWDD waiver services. They must have some proof of neurodevelopmental disability prior to the age of 22. So AHRC, during the 3 years of operation, have served approximately about 8 to 10 patients per year. Within these individuals served, there typically has not been an extremely long wait list, with an average of 1 to 3 people waiting for a bed. So you can see the metrics, that the length of stay, placement, and total savings. The next page is the cost comparison. So this data is on the chart. It's from patients admitted to AHRC Respite House from 19 through 20. It includes length of stay per person, a comparison of costs if the person was still in the hospital compared to what an AHRC costs per day. So the average that we just took average, I think it was Kings County?
Yeah.
Average, and that's how much it would cost comparative.
Can I just ask real quickly, so is that your variable cost in the hospital, or is that your total cost? Do you know?
The total cost per day per stay.
So it includes the fixed cost?
Mhm.
Okay, gotcha.
And it might be different depending on the facility, but that was we use it from Kings, yeah.
Okay, next slide. Possible reimbursement revenues. To date, there have been no reimbursable services through AHRC respite house per se. However, with staffing, the program and potential offshoots of the program of qualified licensed health professionals, there could be a billable revenue from crisis work completed in the community which can be reimbursed. And working with partnership with OMH and OPWDD to create a similar services to this pilot program. The timeline of the RFP, as you can see, and in addition, the Office of Behavioral Health is actively pursuing additional funding streams from the Office of Mental Health, OPWDD, Office of People with Developmental Disabilities, and other possible grants. This is the contract history so far and the request for a 5-year, 3 years plus 2 renewals. Overview of, this is the overview of procurement. We had 5 vendors attend the proposal conference. 2 proposals were received. 2 vendors presented proposals to the evaluation committee, and the committee had graded AHRC the highest. And this is the criteria, minimum criteria. Applicants must be nonprofit entities with at least 3 years of experience providing respite and crisis services for patients with IDD, psychological testing for individuals with IDD, an annual revenue of $1 million. And to the right, you see the evaluation committee type of the people that were on that. This was the performance review for AHRC, and you can see how they graded. Next slide.
Can I just say this real quickly on the grading system? I've seen others where it says exceptional, so satisfactory. Does that mean there was some issues, do you know offhand, or is that just quirk in the way we do these things?
I think that's just, I don't know if the total answer, but I think there wasn't anything, there was no glaring
Right.
problems with it. I think this just means that it was like pass or
All the
fail.
criteria basically
like
were
a pass
met,
or fail
but, I gotcha. All right.
Doing it.
It's a little different because it's a nonprofit. The ones we're usually looking at are for-profit.
And I was gonna, also on the reimbursement slide that you had there, or the ideas on reimbursement, I guess I'm trying to understand, if now there's no reimbursement, who's gonna do that work to figure out how we can get that funds? We do it, or they do it, or,
So there's
trying
staff.
to understand who will do it.
Yeah, so potentially there's some of the clinical staff that work there that could, they already have a partnership with Mother Cabrini where they do some crisis work in the community.
Yeah.
So there is some licensed professionals that can go and actually do the pre-work before they get to a hospital to avoid the hospitalization. So that would be kind of the idea. And they might have to add a few clinicians to do that if it's a larger 5-borough project. But there is people that already do it pretty actively in the Bronx, Queens, and Brooklyn. So that'd be one area where they could expand on that. And then there's other talks currently happening with Office of Mental Health, but also Office of People with Developmental Disabilities to try to enhance some of those crisis services where we could actually get some revenue from it that could be attached to this project. So that is in the works, and we'd have to kind of develop some other partnerships with that. But the current program does have, in addition to having the house, they have a team that helps with behavioral crises in the community in a couple of the boroughs already, so we can maybe enhance those services and bill for those crisis revenue-based services
So question,
in addition to those programs.
question on that. So who's getting that income then if the billing is done from the staff there? So in other words, it wouldn't be in
So that would be
place of dollars to us, it would be potentially additional revenue to them, right? Because I think the real issue here is.
That was my question. 'Cause
Yeah,
it's-
that's the real question,
It's a
right?
guaranteed, they have a guaranteed income, so why would they do all of this? I mean, the reimbursement side.
I mean, it is going as it stands now, but we could figure out, and we have a good partnership with AHRC, so we could figure out a different way to have some other clinicians be able to do that work, and the billing could go through like OMH crisis services type of billing, which bills at a pretty high reimbursement rate, and that could be going back to health and hospitals to kind of help support this program. But that would have to be a new revenue line that'd be set up from how it currently
Well,
stands.
let me suggest, based on what our 2 board members have said, a slightly stronger position.
Mhm.
the Office of Disability, well, let me start. It's a wonderful service. We've gotten only the nicest comments, and you can see what a valuable hole it fills. And certainly as the brother of two developmentally disabled adults, I'm aware of all of the gaps that exist for adults. The services work pretty well till you're 19. But then life continues, and it turns out that it's very difficult. The financial responsibility for these services is not with health and hospitals. This is very clear. This is a state office of developmental disability responsibility. And I'm fine with the idea, and I think it was a good thing that we used one city dollars as waivers in order to see if this was a workable model, right? Because you could say, well, who knows if there's really the demand? Who knows if it's really going to work? But I think having proven it, the state has to pay for it or it needs to go away. Not because it's not a good service, but because this is not the mandate. I mean, I can give you from my brother and sister a long list of holes in the system for developmentally disabled people. If we're going to now prioritize that, we could probably spend almost our entire budget just filling the holes of what is not being done at the state level for the developmentally disabled. But respite services are not a health and hospitals core service. We don't do it for anybody else. And again, I think that the model is great, and I think that using the waiver was wise. But I don't think going forward without a plan of how this specifically changes from funding that we could be using to fix our buildings, to provide care for the uninsured, which is our goal. I mean, again, as meritorious as these individuals are, they're not uninsured. They're all insured. All insured under Medicaid. It's just that respite is not covered because it was the designation for paying for these is all the State Office of Developmental Disability. That is who is responsible for providing these services. And so I think we have to have a plan in short order on how either the service morphs to something that is reimbursable. I mean, inpatient psychiatry is reimbursable, and some of these patients are on the line of, what would be required. But it can't be that we're going to, for the rest of, time, provide the service unless the board, seeks a different mission on what it is that health and hospitals
I
is
think
supposed
you've
to do.
verbalized exactly the concern and the issue, which is no other hospital naturally is going to do it because they're not getting reimbursed. And so the question is, does the Office of Mental Health understand that we are doing this, whether we have to change the structure, maybe we're renting these beds, I don't know how it has to be done to be able to get reimbursed, but I think unless there's some long-term plan for that, and not just some hope, but rather something
Right, a plan.
structured, a plan, then as Dr. Katz says, it's a question, do we spend the money there without reimbursement? And as much as I appreciate this process of, well, it saves money, it's such a complex concept. When you look at the variable costs of keeping an empty bed filled with one of these patients versus paying on a regular basis, it becomes fuzzy about whether there's any savings or not, as much as I appreciate typically and how the system is benefiting. Because the whole concept of the system does great with this, but unfortunately, then the system has to pay for it. And I think that's a real difficult issue. So, yeah, I think that seems to be the kind of the key issue, if we could get that negotiation clearer. Because again, when it was under disparate funds, it was brilliant because, hey, that's what disparate was for. How do we save money for
Right,
the system?
innovation, creativity,
Right.
but now we did that.
Now, Health and Hospitals is going to take the burden uniquely. Then we need to know that there's some mechanism here to.
It could be worded, I mean, in this case, I think the board review is helpful because we can begin our conversations by formally writing and saying that our board heard this proposal and applauded the the idea, the creativity, the use of the waiver, the success of the program, but expressed tremendous discomfort with the idea that health and hospitals, whose mission is the quality care for low-income and uninsured people, has an unending cost responsibility for a respite service that is clearly within the purview of the Office of Developmental Disability. And we would like to continue to provide this much-needed service for the community, but it needs to be paid for. It can't be a strictly health and hospitals, not when it's not a medical service. I mean, again, there are many non-medical services that are much needed in New York City, but that's not what our mission is. So I think using the board, right, because it always reminds people that there's a fiduciary responsibility. It's not that we just get to decide this is good, this is bad, right? There are articles of incorporation, and there's a board, and there's a fiduciary responsibility over what we spend our money on. And respite services, however valuable, are not, especially, long-term for developmental disability, which is a carve-out. That was the word I was looking for before. Developmental disability services are supposed to be a carve-out. They're supposed to be handled at the state level. That's how they're different than most medical services. So we'll do that.
And let me just say, Sally Hernandez-Pinheiro is a committee member. She is actually present on the TV there, but she's not here, so she doesn't have a ability to ask questions or to vote. But she did ask for a couple of things for me to mention, which sort of, I think, dovetails on what Dr. Katz already said. But one question she had was with the company here that we're dealing with, what percent of their book of business is health and hospitals, since no other hospitals are doing this? And since there doesn't seem to be a reimbursement formula for them, they're not Article 28 and so on, they're not a assisted living, et cetera. So that was one of her questions. The other had to do with, related to the type of patients, selection process. Are these all behavioral health patients on top of being disabled or developmentally disabled, or are these across the board people that are having difficulty finding housing and so on? So those were two questions. I hope I reflected them correctly. Sally could listen, so you could nod if I did. But anyway, so just to those questions, and then I guess we can.
So I guess for the diagnostic part, all these individuals do have comorbid mental health diagnoses, pretty complex ones, in addition to having the intellectual disability or autism or some kind of neurodevelopmental disability. So they're complex for many reasons. I think you brought up earlier about they could be an inpatient psych unit, but particularly for billing purposes and things of that nature, many hospitals won't admit this population because of having intellectual disability or autism. Obviously, we have one at Kings County, but these people don't have a place to live, so that's an exclusionary criteria for us. So I think it actually does address some things as far as the complexity of their medical and behavioral health needs, because they have many complexities there. And also, the reason why they're living in one of the various health and hospital system is because they don't have a place to live. So technically they are homeless, because that's why they're living there waiting for housing. So something to kind of also think about and consider is that if not this, then they'd be, again, in a hospital, whatever it's a CPAP or inpatient unit, without a place to live. So, it's hard for a large system like this and there's many, if we did a epic search of those individuals, there's many ALOC patients that meet this criteria. So, that we're not getting paid for, I'm assuming, because on ALOC status. So, to kind of think about how those things interplay and and there is clinical services being delivered in this respite model, so there is a lot of behavioral health services being delivered. Again, with reimbursement and rates with that, it's another question that we can think about. And the first question was, forget the.
Yeah, related to the percent of book of business of this, what do we represent? Are we 100%
Oh, okay.
of their book of business, basically, other than what you mentioned with the grant they have from Cabrini and some community work and so on? But for the most part, they exist because we have this contract. Is that fair?
The respite house, yes, but they have other services. It's a
Right,
large
understood.
agency in New York City that provides these services through Office of Field Developmental Disabilities. But yes, it's part of.
And then just to get to the really critical question, I guess, because it's the end of March is when the contract is over. Was that correct?
And it's March 31st.
Yeah. So then the question becomes, it sounds like we have a lot of homework to do between now and then to see if there's some process.
We can't, these are very vulnerable clients. I wouldn't feel comfortable suggesting that the service ends now, because it's gonna, anything with the state and political stuff is gonna take us months.
I agree. So I think that's
So
the
we
question.
go-
How do we
I'd like the
rephrase or
contract to go
reframe this?
forward, but the contract can end
Right.
if we're unable to secure funding, right? I assume the contract has a, what is the provision for ending the contract?
So on the bottom of page 11, it says H&H will also be able to end the contract after year 3 or 4 by opting out of either renewal. Richard, so I think that covers the question.
It's 3
We
years with
can
2 one-year
terminate it
options.
year
So we
3.
can get out after the 3rd year if we wanted to, and we can.
But I think, again, from the legal, we would need to have this verified. There has to be, unfortunately, a clause that within the 3-year
In the
period,
contract.
we have the right to terminate without cause.
Okay.
And I think that becomes an issue. And obviously, we don't want to do that. And obviously, as Dr. Katz said, we think this is a great service and we don't want to put these people at risk. And if we terminate the contract as of March 31, it sounds like there's no facility.
There's
So-
no other, there's no
Yeah.
alternative. But I think what we'll do before we go to the full board is that we will work with the contractor. Also, by the way, this helps in lobbying, right? Because once you inform the contractor that we're going to eliminate the contract in a year unless the state office helps, then they will become very motivated to lobby with us to get the contract, right? So we will write the contract so that it's understood it's not their performance. We're not ending it because of their performance. But that if we are unable to secure beyond the next year, then then the service will have to end. And the knowledge of that, I think, will enable us to motivate. There are a lot of different ways this could be provided revenue, and to be honest, I wouldn't even mind if we were a contributor. It just can't be wholly our responsibility that we uniquely, not any of the other hospitals, not the state, not Medicaid, right, that we uniquely have to provide a respite service that they're ill-equipped to provide. That just can't, that's unacceptable. So we will fix and get it 1 year. And Coalicia will advise on how you want to deal with the resolution today, if you want to say that or how you want to deal with it.
The committee can approve the action item contingent on a 1-year termination
Clause in the
clause
contract.
depending on state funding.
Other funding.
Or revenue.
Other funding,
Or
other
revenue,
revenue,
yeah.
funding source, yeah.
Right, potentially grants, whatever. Yeah, so but I think it has to be reworded to say 1 year rather than 3 year with the
Yeah,
ability
1
to
year.
terminate. So it would be a 1
We
year.
will change it.
And we can do with yearly potential, based on our decision. So I think, so Khaleesi, you'll.
I think she just gave you the wording.
Excellent.
If you're otherwise good, you'll approve it today
Okay.
with the provision that the contract has a clause that it can be ended without cause in 1 year. And then in that will give us a target, and again, it works well with the state. We'll write them we'll start with a nice letter and follow it up with context saying that our board was concerned, fiduciary responsibility, recognizing the vulnerability of the clients, agreed to go for another year, but not beyond that year, need help on how to fund this critical model.
That's the new resolution, what you just said. So, so other questions before we take a vote on that resolution? No
questions.
No other questions? All right. Let's take a vote then. Dr. Katz?
Yes. Yes.
Okay, Dr. Pagan and myself, yes. So that's, that resolution in its modified form passes. And let's go on to the next resolution.
The next resolution will be discussed by Mr. Joe Wilson, Senior Assistant Vice President, Supply Chain Services. The resolution is authorizing New York City Health and Hospitals Corporation, known as the System, to exercise a best interest extension for 3 months on its existing contract with Crothall Facilities Management, known as Crothall, for biomedical program management for the amount not to exceed $9,369,806 for the 3-month extension period. Mr. Wilson?
Good morning. Next slide, please. Crothall Facilities Management Incorporated, known as Crothall Healthcare, manages biomedical services for all New York City health and hospitals locations, including acute care, Gotham, long-term care facilities, as well as correctional health. The agreement provides management staff as well as equipment maintenance. New York City Health and Hospitals contracted with Crothall Healthcare Services as a result of an RFP in 2014. The Crothall Biomed agreement was board approved with a not to exceed cost of $252,884,799. The RFP and agreement were being managed by the Office of Contract and Control, and in 2017, the Office of Contract Control merged with Supply Chain. The agreement and relationship management were transferred to Supply Chain. Over the course of the agreement, the scope of work expanded to cover services such as dialysis, lab equipment, chillers, stretchers, correctional health equipment, IT support, and included warehousing and transportation. The current agreement expires March 31st, 2023. Per OP 100-5, New York City Health and Hospitals has issued an RFP to identify a provider and award an agreement for the next 10 years. The new RFP scope of work has evolved from break-fix to full management program, which includes equipment repair, maintenance, equipment management, IT support, warehousing, and transportation. The initial timeline to complete the RFP was extended due to the enhanced scope of work. We needed more time. We needed to add to the timeline to develop the scope for each service vertical. We wanted to include facility leadership, IT, nursing, and other service lines, which caused us to extend the target date. New York City Health and Hospitals seeks to extend the current agreement with Crothall Healthcare for an additional 3 months under the best interest expansion to provide services until the new agreement is implemented. This slide right here is just a little bit of a kind of a pictorial of what the future state will look like. Besides equipment maintenance, which is what we do today, which is kind of break, fix, PM repair, and the life cycle management, we wanted to add in biomed IT support. So from 2014 until 2023, we're a much different organization. We now have a fully integrated EMR, a fully integrated ERP. We're much more, all of our equipment now kind of receives and accepts information, billing support, and also we need extra support for IT security to kind of mitigate our device vulnerability. We also added warehouse and transport as we started to use those services during COVID and realized the value of them, of being able to move our equipment back and forth in kind of these critical times, and the ability to warehouse our COVID critical care equipment, as well as a staging ground for large implementations of equipment. And the last one is equipment management, which is where we'd like to bring about kind of a standardized way that not only do we clean our movable equipment on the floors, but to properly par level it in the clean utilities. Also bringing about another series of checks to the equipment to make sure all of the equipment that nursing picks up is ready, just not powered on, but potentially having people look to make sure it's running the right version of the drug library, knowing that it's been cleaned as per the IFU, no more searching. So this would take place on the nursing floors as well as the ED, and we would integrate this along with the biomed program to kind of ensure that not only is our equipment, always ready, but properly cleaned and easily found. Next slide. So the vendor performance. So Crawford's done a really great job. They've been rated strong, not just because of their day-to-day work, but really their tireless work during the pandemic, where they were really partnering with us to move equipment around, help us to source difficult equipment when there was, a true stretch to find enough ventilators, patient monitoring equipment. So as we have evolved as a company, they have evolved their services as well. Next slide, please. And the request is to authorize New York City Health and Hospitals Corporation to exercise a best interest extension for 3 months on its existing contract with Crawford Facilities Management for biomedical program management for an amount not to exceed $9,369,806 for the 3-month extension period.
And my only question would be, do we feel that 3 months we're down the road enough that we can
Yes,
be able to come to
we actually have already done our first round of scoring. So, yes, I think as long as we make sure we bring everyone, it's quite a large committee. We have about 26 members, so lots of doctors, nurses, chief executives, nurses, infection prevention. So as long as we bring them all together, we hope to have our scoring done in the next week or so and then continue to march this forward.
Other questions?
Is there something different about the way you're doing the RFP now that you did in the past? given
Oh,
the
yeah.
engineers
Yeah, it's
changes
completely
and all
night and
that?
day. As I said, we were kind of a completely different system when it came to technology. So IT is really on the forefront just for security reasons, IT connectivity, our ability to kind of send information in a safe way. That's number one. Number two, when this contract started in 2014, the system owned about 67,000 pieces of equipment. It owns over 120,000 pieces now. So we're much larger and also we're further defined. When this contract was written, it was during the old network model. So, McKinney was kind of lumped in with King's, and it didn't really differentiate amongst the specific needs of biomed for long-term care versus acute. So we really have 3 service models, an acute model, an ambulatory model, and a long-term care model. And then over that, we envelope in the specific IT needs, the equipment management needs, the warehousing needs. So it's really this kind of perfect moment to kind of reset the table of how we deliver this service.
So that's part of the conversation in the score, not the scoring, but the whole process. I
Oh,
guess.
yeah. Yes.
Other questions?
Thanks.
Sorry.
That's good, it's a good scope of work, Joe, and
Thank you.
All right, let's bring it to a vote then. Dr. Katz?
yes.
Don?
Yes.
I'm a yes as well, so passes unanimously. We can now go on to the Chief Medical Officer report.
Thank
Dr. Allen?
you, Dr. Calamia. I am presenting today for Dr. Omar Fatal, who, as we speak, is at the City Council hearing on Mayor Adams' proposal to bring homeless, addicted people who might have potential harm to themselves, bringing them forcibly into our hospitals. So he has a very important task this morning. What he asked me to present to you is what we're doing with suicide screening and assessments in the psychiatric emergency departments and the psychiatric inpatient units. The Joint Commission actually requires that all behavioral health patients have a comprehensive and complete suicide screening assessment. The suicide screening assessment tool that we use is known as the SAFE-T, S-A-F-E-T. This is a suicide assessment 5-step evaluation and triage. The 5 steps that are included in there are the Columbia Suicide Severity Rating Scale, which is known as the CSSRS, the Lifetime Behavior Assessment, the Risk and Protective Factors Assessment, the Risk Stratification, and the Formulation. In addition to that, we have recently had an adverse event which drove home the need to actually comply with this risk assessment and screening. The next slide, please. Behavioral health, nursing, and providers. We had a training that was initiated in October 22 for the nurses as well as the providers. In addition to that, we optimized our electronic medical record so that there is a best practice advisory that addresses the Columbia screening and risk assessment. There's a BPA for the lifetime behavior, so that if it's not done, a BPA actually is launched to remind the provider to do such. There's also a new BPA for suicide risk stratification and formulation. And at the end of the day, there's a hard stop on the inpatient side that no behavioral health patient can be discharged without this being documented. The safety protocol, as I said, has 5 stops. The next slide, please. Has 5 steps. The first 2 that you see there is a suicide ideation for the severity within the past month. Then there's a suicidal intensity assessment for the past month. And then there's an assessment over the lifetime behavior for a history of suicide attempts. There's also an assessment of the risks factors as well as the protective factors within that exist for this particular person. There's a risk stratification that decides or categorizes the risk as either low, moderate, or high. And there's a formulation, which is the summary of the plan. Just quickly going over these screenshots from Epic. This is the past month assessment. You see a blank that says go back. If it's not documented, if someone is checked off unable to access or not applicable, they must put a reason in there, must document the reason. In addition to, there's a question about the lifetime risks. Over your lifetime, have you ever done anything, started to do anything, or prepared to do anything to end your life, yes or no?
So just clarification, so in the pathway in Epic, which patients are actually going through this pathway?
All patients.
All. So technically, via Epic, you wouldn't be able to complete this record unless you had 100%
Exactly.
compliance. Okay.
But when you say all, you mean all behavioral health
Behavioral health
inpatients,
patients,
not medical patients or surgical patients.
whether they're in the emergency room or the inpatient side.
Gotcha.
So there's a recent assessment, the past month assessment. Once again, if the patient's not assessed or it's judged to be not applicable, the provider must fill in the reason why they did not complete that. If you go to the next slide, so there are 2 questions about the past month, then there's a question about lifetime behavior. The question is, over your lifetime, have you ever done anything, started to do anything, or prepared to do anything to end your life? It must be, if you don't complete this, you must document the reason why. The next slide is a screenshot of the suicide risk stratification, whether the patient is high risk, moderate risk, or low risk, and a formulation must be documented. What is the plan? Next slide. Effective November 2022, this is the inpatient side. You can't discharge a patient without this assessment being completed. Next slide. So the training was implemented in October 22nd, and each of these lines represent a portion of the safety screening. We were pretty much at the 100% level for the lifetime behavior. If you look at the risk stratification, we went from 83% up to 97%. If you look at formulation, that actually increased as well. So there was a marked improvement. If you look at the blue line, the lifetime behavior, doesn't seem to be much difference. In investigating that, there was actually a loophole. You could check a box that says I'm not the primary provider and it doesn't get completed. That has subsequently been fixed.
You answered a question I was about to ask, so.
Yeah.
Because unfortunately, docs are very good sometimes at being able to get out of locks in medical records, but creatively, so that's great.
So that is the improvement wanted to present to you. And looking at since June 22, the number of completed suicides we've had on the inpatient side is 2. We had one in July, one in September, so thankfully it's a low number. Just to documenting any decrease would be very hard. There were a number of months that there were zero. Um, so it's a small volume, and we just want to do the best we can in identifying those patients who are at risk. Any questions?
No questions.
In addition to that, what you have in your packet, which I'm not going to discuss, is the additional MMPA initiatives. If we can just run through this quickly, I'm not asking people to speak to it. We're
So why
doing,
don't we let it go in writing?
it's
Because
it's submitted.
it's very comprehensive, it's good, but we have two other reports.
Okay, and the team is with us here.
Thank you very much.
No other
So,
questions?
any questions?
It is very detailed, as Dr. Katz said, and so it's worth reading for those.
Absolutely.
All right, let's move on then to the next report, our CNO report. Albert Valero, I believe you're gonna.
Good morning. I'm reporting on behalf of Dr. Natalia Sinis. This is the System Chief Nurse Executive Report. Next slide. We're sharing our Nurse Excellence Awards done in December. We had increased amount of nominations and overall awarded 34 to staff, and that happened on December 5th. Next slide. We have fireside chat documentation. That is an iteration of a bi-monthly series where Dr. Sinis broadcasts with the system and chats with staff, frontline staff, and the recent topic was documentation, and that happened December 2nd. The Braun pump rollout happened at Lincoln Hospital with collaboration with central office and the leadership at Lincoln Hospital. Next slide. We have a recent Beacon Award celebration awarded to Bellevue CCU, which is a gold level Beacon Award, and the Beacon Award is a award from the American Association of Critical Care Nurses that aligns that unit's practices to the healthy work environment standards of the association. Next slide. Nursing Quality Council has a fall prevention committee that had its first meeting and also added a pressure injury prevention and wound care council in that committee for 2022, and they completed several steps in terms of completing a transition of care protocol from patients discharged with wounds that require home care nursing visits, education content for new electronic system, pilot and approval of new incontinence management system, and work with IT to improve wound care documentation. Next slide. Our successful nurse residency program continues, which was launched in December of 2018. We've graduated 420 new hires or new graduates, so far approaching 200 EVP projects, and we added curriculums on wellness, interprofessional communication, and educational offerings for RNs in collaboration with the Learning Academy at the Human Resources Department. Thank you.
Excellent report. Any questions at all? I'm remiss, Dr. Martone joined us, who's a full voting member of the committee. Welcome, thank you. Any questions? All right, let's move on then to our last report. Betcher Plus.
Morning. So I'll start with some important regulatory highlights. There's a lot that's going on, but just the really consequential ones. So the restarts are back officially. They will apply to people with a restart date of June 30th of 2023. We had a lot of kind of almost throughout the last year thinking that the restarts are coming. Now it's official. What the federal government has done, it divorced essentially the public health emergency from the moratorium on restarts. So although the public health emergency for now is going on, I think it's now expected to expire. Those two are separate, and so we kicked into high gear preparing for the restarts. there are different estimates of how many members potentially can lose their coverage. The industry estimate is about 20% of people can actually lose their coverage. There are a lot of things that we are doing, uh, both in terms of building an entire notification and alert system to our members, building an entire program around contacting providers. In preparation for that, we are actually deploying what we call concierge services into all 11 acutes, meaning that our research specialists will be sitting at H&H facilities helping people to not just enroll, which is something we do day in and day out, but also specifically to recertify. We're also planning on doing community events where people will be able to come in and recertify. And finally, we are starting now to run a pilot at Elmhurst where we positioned a kiosk of self-service. A lot of the members are just not able to deal with all of the paperwork, print, right, photos of the documents that they have to submit. This kiosk will be able to help them. So there's a printer, there's a scanner, and there's just an online ability to apply and recertify. So we're starting with Elmhurst. The machine is already there. I just saw it on Friday. It will be activated in the near future. If we see that there is an uptake in utilizing this kiosk, we will deploy it into all of the facilities.
So just to be clear, the recert process, although June 30th is literally the time of potential termination if they're not recerted, but that recert can be taking place or is taking place now, can take
So,
place now.
right, so we're starting in April. So this is the prep to get started in April, so we are completely covered as much as possible for June 30th.
So hopefully, we should have at least some early idea as to how many literally will lose coverage completely, how many may be shifting into other products, and so on.
Right, we're doing a lot of pre-work. One of the things other plans are doing, us included, is essentially looking at financial data in the zip codes where we have a lot of membership, seeing what the financial data is telling us in those zip codes, and then proactively reaching out to members in those zip codes saying, it looks like you probably will not be eligible for Medicaid, but you may be eligible for AP or subsidized QHP. So we're doing this proactively. The other really critical piece of this is just having accurate contact information for our members. Um, Luckily, to some extent, for us, we just launched a new dental vendor, 1/1 of 2023. What this means is that we send new membership cards to our members. We are now tracking, we have been tracking all of the return mail for those who did not receive those membership cards and making sure we chase those members and update their contact information. Contact information is one of the biggest barriers for recertifying members. So there's a whole playbook that we have in collaboration with health and hospitals to make sure that we are as ready as we can be and minimize the number of people who actually lose coverage.
Talia, I've noticed in my own patients, the things that I can generally depend on are their cell phone number, not their address, and their ability to photograph things on their phone and send them to me.
Yes.
But definitely, people are not on email. They are not particularly good at going onto websites. But the phone, and I've had a lot of success. Like, take a picture of that medicine bottle for me, or they'll even do it on their own. That part of the technology is working. So I don't, so I mean, like people, the old sort of scan, if you tell people to scan a form, it freaks them out
Yep.
because they don't think they can scan. But if you tell them to take a picture of the form, if that works for your purposes, I find most people can in fact do that.
So in terms of our outreach, you're absolutely right. We do multi-prong. We
Right.
do mail, email, text, repeat, repeat,
Sure,
repeat.
sure.
So we're doing all of it. In terms of taking a picture, the way the regulations here work, if they take a picture, they can upload it into the state website, but they cannot send us the picture to upload it. So what we do is we tell them how to upload the app for research, and then we walk them through how to upload their
I could see how you
documents.
would have to do that. Certainly for the majority of my patients, you'd have to do that. They would not be able, they could send you a picture,
Yeah.
but they would not be able to upload a picture onto a website.
Right, so this is something, I mean, and you have to download the app first. You can't just send it. So it's a lot of hand holding. We planned for it. We expected the research will come back. We invested in our research team. There's an entire team that focused just on that. And that's what they will be doing.
And are you allowed under current regulations to reward people with food vouchers or other sort of non-monetary things?
We have something that's called a module, to teach them how to do this. If they complete a module, they get money loaded into their card. So that's what we have.
So for people that do not recertify, do you have a way of tracking like then what happens to them? Meaning like, or at least asking them, so that you know how many of them you turn in, they went into another product, they became uninsured, or what's happening to them?
So obviously, if they switch to another product in our plan, we know. If they switch to another Medicaid AP plan, we know. If they became completely uninsured, or we don't know.
Yeah.
So there is a limited visibility to what happens.
People will just disappear. And some of that's okay in the sense that they had a medical need. At the moment, they don't have a medical need, so they don't. It's hard to convince people if you don't have a medical need to do it, and especially young men, right?
Young black men.
Right.
That's the population that we see. Most of the disenrollment happening, the involuntary.
But the good thing is that there isn't a barrier. If they come to us first, of course, even if they're not enrolled, we're not going to turn them away. So they can still get care, and then at that moment we can re-enroll them. Right. So it's not as awful in a system like New York City where there's a health and hospitals. Of course, in other parts of the world where there's nothing, right, people just fall off and they can't get any service.
Is there any way to hook them up with NYC Cares or other?
Well, if they're eligible, we wouldn't want to hook them up, right? NYC cares for people who are not eligible. These people are eligible. They just don't at that moment feel that they need to do the paperwork.
Oh, I see. I
Right.
see.
But if they're not eligible, we have a bi-directional referral with NYC Care.
So
And
if,
on the
if
H-
the person
I'm
does
sorry.
tell you that they, for example, I got a job and I have a different insurance, like Aetna, do you have a way of capturing that information at that point for our data purposes?
Yes, manually.
But they'd
So
have
it
to
will be
tell
a
you.
it will be a one-on-one interaction. We don't have a way to kind of scan the population and tell ourselves this is what happened. Sorry, was there?
All right, very good. You good on the report because we're at time. Is there anything else important that you want to pass to the board?
Just the pharmacy. So the pharmacy carve out for now looks like it's a go. April 1st is the date where pharmacy goes back to the state. There are clinical care management financial implications in the budget that the governor just presented. She was still talking about the carve out, potentially moving the presumed savings, I should say, back into the providers. So still doing the carve out, incurring savings, and then redistributing them to the providers. We have a lot of skepticism around this approach and whether the providers will actually see any kind of savings. We continue to lobby against it. For now, it progresses towards a carve out.
I've lived long enough to see the state give the providers the plans, the pharmacy, and I expect to live long enough to see the state give it back to the plans. I think this is not going to work. I think they're going to do this for a couple of years, and then they're going to get too many complaints, and then someone is going to make the bold initiative to put the pharmacy back to the plans, and they'll call it something different, and we'll be back where we started.
Call it reinventing the wheel.
Yeah, yeah, but they'll call it re-envisioning
Yes, of course, of
pharmacy
course.
benefit,
As we're
pharmacy
improving.
choice plan. They'll have some name for it.
I agree. Any other questions or new business? There being none, meeting is adjourned. Thank you all.
Thank you.
Thank you.